topic is host modulation therapy. Now what do you understand by host modulation therapy? We know that initially, before they even determined the pathogenesis of periodontal disease, initially they thought that the pathogenesis or the pathology behind the development of periodontal diseases was purely related to the bacterial etiology. And then later, over a period of time of constant research, they realized it is just not the bacterial etiology that plays a important role, but it is your host response. Means the way the body or the immune system responds to the bacterial antigens. And then they said that the interaction between the host and the bacteria together result in an altered immune response, wherein there is a kind of an imbalance. If there is an imbalance after the host bacterial interaction, if there is an imbalance that is created between the destruction and the reparative processes, this will lead to an increase in the destructive process, which can further progress to what is called as your periodontitis. Now, this host modulation therapy has a major important role in altering this host-mediated immune response before either during the initiation stage of periodontitis or to stop the progression of periodontal diseases. That's why the term host modulation therapy means the therapy which is initiated or which is given in order to modulate the host body response so that it can take in the amount of bacterial or it can withstand the amount of destruction that is caused because of the host bacterial interaction. Now this slide indicates that whenever there is a host bacterial interaction, this results in an altered immune response or an altered individual response to the bacterial challenge. And this will result, if this alteration is too much and then if there is an imbalance, this will lead to the disease process, that is your periodontitis. So where does your HMT play a role? It plays a role in altering the immune response of the individual, therefore limiting the development of periodontal diseases, either at the starting stage or the initiation of the periodontal diseases, or it will help in the regression or preventing the progression of the further disease process. Now you know that most of the time the bacteria and their products are they include most of the periodontal pathogens are gram-negative anaerobes, and these organisms liberate lots of endotoxins, and they bear something called as virulence factors. Now these virulence factors, meaning they can be the cell adhesive molecules, or it can just be the fimbriae of the bacteria, or it can be the pili or anything. Okay, so the entire organism, or it can be just the phospholipid layer of the bacterium, which can be viral, or just the capsule of the bacterium, which can be or which acts as your virulence factors. Now once the bacteria with the most virulent factor enters the tissue of the host, what it does is it slowly tries to evade the host tissues and enter or penetrate the host tissues and then cause its effects on the periodontium. Now, so the bacterial products, when they stimulate the host cells, the host responds to it by the process of inflammation. As a process of inflammation, it releases certain mediators, which include your prostaglandins, your cytokines, and your matrix metalloproteinases. Now these matrix metalloproteinases are nothing but your collagenases, your stromiolysins, your matrilysins, and then your gelatinases. Now all these are enzymes basically involved in breaking down your collagen and other proteins of the body. The most important one is of the MMP is your collagenases. Now normally also, without a stimulus, your body itself produces collagenases, which are important for the breakdown of collagen. But then in case of a bacterial challenge to the host releases excess of these MMPs, and then it can be released by mainly importantly by the macrophages and your neutrophils. Now apart from that, your MMPs can also be released by the other host cells like your epithelial cells, your endothelial cells, your fibroblasts. But then in case of a bacterial challenge, stage, there is an excess synthesis of these MMPs by your neutrophils and your macrophages. Now, as a result of the involvement or the release of all these mediators, that is your prostaglandins, cytokines, MMPs. The cytokines include your growth factors, they include your anti-inflammatory cytokines, you have your pro-inflammatory cytokines like your interleukin 1 beta, alpha, then you have your TNF alpha, that is tumor necrosis factor alpha, and the anti-inflammatory cytokines include your interleukin 10. Interleukin 8 is also one of the important pro-inflammatory mediator. Now all these, what do they do? The main role of all these mediators is to stimulate your osteoclasts. They have an effect on the osteoclast and they cause about stimulation of these osteoclasts, and the further stimulation of osteoclasts will lead to bone destruction. You know the main function of osteoclasts is to resorb the bone. So once they get stimulated, they are having a good atmosphere to resorb the entire bone there. Now your MMPs at the same time are going to act on the connective tissue collagen fibers and then break down all the collagen. So once your osteoclasts have resorbed the your inorganic matrix of the bone, the MMPs or the collagenases will act on that area and remove the organic constituents of your bone. Apart from that, they also cause lysis of your periodontal tissue, periodontal ligament connective tissue, your gingival connective tissue, therefore leading to pocket formation and increase in the clinical attachment loss, and then further leading to tooth mobility, and then one fine day the tooth is out of function. Now, this is the entire clinical sequelae that happens after the body has received a kind of a bacterial antigen. Now, how do you manage? Now, when you know that the patient is being diagnosed with the form of periodontitis, be it chronic periodontitis or be it aggressive periodontitis, the main treatment or the major challenge to the periodontist would be how do we treat the periodontal diseases. You know that the periodontal diseases, even just after treatment, it's just not enough. The main important factor which plays in the prognosis or the stability of the periodontal treatment would be the proper maintenance of the patient. If the patient is not able to maintain well, then whatever the treatment you have done is going to be finally unsuccessful. So what are the treatment strategies that you can think of for periodontitis patients? A complementary strategy, treatment strategies. They include good patient education and motivation regarding the effects of the importance of oral hygiene, regarding the importance of the factors that can cause or that can contribute to the periodontal disease, like your environmental factors, that is your smoking, and then stress reduction protocols. So all these have to be educated, and you have to motivate the patient in order to quit any of the factors or the habits that can cause your periodontal or contribute to the development and unsuccessful therapeutic outcome. And then you can also involve your use of antiseptics into your routine periodontal treatment protocol. Apart from that, you have to explain the patient the rationale or the importance of your adjunctive therapeutic procedures. And then the main important one would be your scaling and root planing, which is important to reduce the bacterial burden. First, you have to eliminate mechanically all the local factors, and then only you can go ahead by doing any other procedure. Most of the times what we do is you do a scaling and root planing, and along with it you do some adjunctive measures. Probably you can put the patient on some oral your mouth washes, that is your chlorhexidine antimicrobial mouth washes, or else probably you can do an antimicrobial subgingival irrigation systems, your local drug delivery systems, etc. The site-specific antibacterial treatment with local drug delivery or systemic antimicrobial therapy will also be one of the complementary treatment strategies that is available today for managing periodontal disease cases. And then host response modulation through HMT, that is host modulation therapy, is one of the treatment strategy. And then risk factor modification and risk reduction strategies, that is your educating or you're helping the patients in quitting the habit of smoking and things like that. And then the last would be involvement or incorporating periodontal surgical procedures with or without host modulation therapy. Now let's see, how do we reduce the bacterial burden? Now these are the treatment strategies which include your SRP, that is your scaling root planing, topical antimicrobials, and then surgical pocket reduction therapies. The risk factor modification, it includes modification in smoking habits, that is smoking cessation, and then diabetes control. Apart from that, the host modulation part can be covered by including certain kind of drugs like your sub-antimicrobial doses of your doxycycline as a modulating agent, which will inhibit the formation of your MMPs. Okay, now all these three protocols can give you the best clinical outcome. Now, to prevent disease initiation and progression, mechanical as well as antimicrobial pharmaceutical agents have been used successfully worldwide now. For the long-term clinical management of periodontitis, a novel adjunctive therapies like host modulation has been introduced, which is found to be the best successful therapy. The use of HMT as an adjunct to particularly use it you can use HMT as most of the times you don't incorporate HMT just as an alternative treatment to the regular protocol. You just incorporate HMT as one of the adjunctive modalities of your periodontal therapy. So it can be used as an adjunctive therapy in all these situations, like in patients who are susceptible to periodontal diseases, and then high risk patients who include smokers, your diabetic patients, and the ones who are genetically predisposed to development of periodontal diseases. Now, what are the treatment protocols that you can do? Now, in order to reduce the bacteria and the burden of the bacteria, that is the bacterial products, you can incorporate antimicrobials. Now, the incorporation of antimicrobials will block or will prevent the bacteria to grow, or it will prevent the bacterial products, or it will reduce, basically it will reduce the bacterial burden on the host. And then, once the bacteria are attaining the challenge, it will stimulate the host cells, and then it will release all these inflammatory mediators that we discussed, right? Now, your prostaglandin synthesis can be blocked by incorporating your non-steroidal anti-inflammatory drugs into your periodontal treatment therapeutic regimen. There's something written there which is called as, which is written as Periostat. Now, this Periostat is nothing but your doxycycline, a sub-antimicrobial dose, a 20 milligram dose of doxycycline would help in depleting the synthesis of prostaglandins. Now let's see where your MMPs, we have to inhibit the MMPs. Now your Periostat again has a capacity at an antimicrobial dose of doxycycline, will help in blocking the synthesis of MMPs, or it will help in inhibiting the MMPs. Now, apart from that, you have one more treatment modality here, that is your bisphosphonates, and again Periostat. So that will inhibit your osteoclast, or it will decrease the production of osteoclasts, or it will inhibit these osteoclasts, and thereby reducing the resorption of the alveolar bone. So if you can see clearly that the Periostat has three multifunctional roles here. It has a role in decreasing the inflammatory mediators. It has a role in inhibiting the matrix metalloproteinase synthesis, that is inhibiting the dose of inhibiting the collagenases, and then it also inhibits the osteoclastic activity. Now, the most important host modulatory agent is your Periostat, which is recently approved. Okay, the FDA approved recently approved drug is your doxycycline Periostat for systemic administration as an adjunct to your scaling and root planing in the treatment of chronic periodontitis. Now, you know that normally the doxycycline is a group of tetracycline. Okay, it's a modified form of tetracycline, and these group of antibiotics usually are, they're basically antibiotics. But then most of the times the antibiotic dose of your doxycycline is about 100 milligrams, which is given just once daily. Okay, but then a Periostat, this is a modification of your it means the self terminology is that it is a sub-antimicrobial dose. That means instead of the 100 milligrams, you're giving a stat dose of 20 milligrams to the patient for about a continuous period of about 21 days, or for a period of about 7 days, of 7 to 14 days, 14 days to 21 days, you can give the patient a sub-antimicrobial dose of doxycycline. Now this sub-antimicrobial dose of doxycycline will not show any of the antimicrobial properties. Rather, it will show the non-antimicrobial properties, which include the inhibition of synthesis of MMPs, and apart from that, it also blocks the stimulation of your osteoclasts. And then it also inhibits interleukin 1 beta synthesis from your macrophages. So to conclude, the future holds bright in front of us with lots of adjunctive therapies in order to modulate the host response, and then play an important you can incorporate this kind of a treatment modality or the adjunctive treatment modality in getting a successful therapeutic outcome for periodontally diseased patients. Thank you. The topic is periodontal medicine. What is, it's basically, you can say, as the term itself or the topic name itself determines, it's periodontal medicine. So there's some link between the medical conditions, and then there is some link between the periodontal diseases, or else it can be vice versa. So any of the systemic conditions can produce the periodontal problem, or the periodontal problem can produce your systemic conditions. Let's go a little detail. What is this periodontal medicine? According to the 1996 World Workshop in Periodontics, Offenbacher has defined your periodontal medicine as a branch of dentistry that has, it's basically as a discipline that focuses on validating the evidence to relate the disease relationship and its biological plausibility in human populations with ample amount of evidence in animal models. So basically it is making us understand how well are the systemic conditions linked to the periodontal diseases. Now what we are going to discuss is under the 4 subheadings of cardiovascular system, the reproductive system, endocrine system, and the respiratory system, how all these conditions or all these systems are interrelated with periodontal infections. Under the CVS would be the list of conditions most commonly occurring are your atherosclerosis, coronary heart diseases, your myocardial infarction, angina, and even stroke, that is your cerebral stroke. And then the reproductive system, what we're going to discuss is what is the effect of periodontal infection on preterm low birth weight infants, and then preeclampsia. Endocrine conditions, we would talk about diabetes and its relationship with periodontal infection. And under the respiratory system, we're going to discuss about the COPD, that is chronic obstructive pulmonary disorders, and bacterial pneumonias. Now, if you go to a little back into the history, earlier, before much even the ample amount of evidence is available to date, but earlier there was not much of evidence. They were just based on hypothesis. So it was many authors like your William Hunter or W.D. Miller, followed by William Hunter. Now, these were the 2 renowned personalities who said that oral infection is supposed to be the main culprit for causing any of the systemic diseases. So according to the Miller, in 1981, he wrote one article named as your human mouth as a focus of infection. He said your mouth is one focus of infection, and from here this is the source for causing any kind of a systemic disease. And then it was William Hunter in 1900 who wrote an article entitled Oral Sepsis as a Cause of Disease. Now they even literally became so much boosted about that, they started extracting teeth just because they had some systemic illness. So they felt that by extracting the teeth, it would decrease the systemic illness. So then later, slowly, this theory it went into a downfall, and then because it was just, there was no complete evidence for it. It was just based on a hypothesis. Then slowly this again came back into limelight with Matila, who did a lot of studies, and he tried to prove, or he did studies which showed a positive influence or a positive causality between periodontal infections and systemic diseases. Now, if you take why these periodontal infections can cause any systemic problems, the first thing is presence of constant flow of bacteria. There's a constant pooling of bacteria in the mouth. The subgingival organisms or which survive in the subgingival environment, especially in your periodontal pockets, what happens is they produce a lot of toxins and virulence factors, and there is an increase or excessive load of these microorganisms. So the constant pool of microorganisms which are present in your oral cavity, and if they can be systemically transferred either through bacteremia into the bloodstream and then reach the various systemic organs, can produce your infections in the systemic circulation. Then periodontium as a cytokine reservoir. First is the periodontium as a reservoir for your bacteria, and then the second one is a periodontium as a cytokine reservoir. Cytokines are nothing but chemical signaling molecules which are liberated or which are produced by any kind of a cell in the body. Any cell in the body produces these cytokines, and these cytokines, you can say they are local or chemical signaling or chemical signaling molecules. They especially mediate the process of inflammation. Now, you know, periodontitis is one of the most important, it's a chronic inflammatory condition. It's an immunoinflammatory disease. It's a polymicrobial infection. So as there is an infection, there is a constant chronic kind of an inflammation process that is happening. So the body is into excess production of lot of cytokines. So there is a excessive amounts or pooling or a reservoir full of cytokines which are available for your systemic to produce any kind of a systemic effects. You know, these inflammatory mediators, for example your prostaglandins, interleukins, they do not just have a local effect even though they are produced in the periodontium, but they do have a systemic effect when they are overloaded, abundantly present. Now, the third one, why you can interpret that periodontal infections can be linked to the systemic diseases. The third one would be the shared risk factors that your systemic diseases and your periodontal infections both have in common. Either it's your environmental risk factors or your risk indicators. These include tobacco smoking, stress, aging, and then race or ethnicity and male gender. Now, what are these acute phase reactant proteins? Now, these acute phase proteins are basically, the purpose of the production of these acute phase reactant proteins is to restore homeostasis. Now, these acute phase proteins are produced as a result of any kind of the minute there are triggering factors within the body, as an initial response, their production of acute phase proteins, and then later it enters the secondary phase of reaction, wherein your other mediators are produced. The first mediators that are produced are your acute phase proteins. Now, these acute phase reactions, as it's given, they're produced at a very early or an initial response to any of the triggering factors. That can be one of the predicted reasons. And then we have, first let's talk about the relationship of your periodontal disease and cardiovascular diseases. If you see the both cardiovascular disease, of the cardiovascular diseases, your atherosclerosis is supposed to be one of the most predominant diseases associated with the cardiovascular system. It's one of the progressive disease that involves the large and the medium-sized muscular and large elastic arteries. Basically, there's formation of a plaque within the arteries which blocks the arterial lumen and then leading to the difficulty of inflow of blood. If you see the pathophysiology of inflammation in atherosclerosis, it's basically atherosclerosis again is an inflammatory disease. Now comes up whenever there is an endothelial injury, what happens immediately? There is activation of the endothelial cells. Because of this, there is a lot of production of your cytokines and chemokines. And these chemokines, which are produced by the endothelial cells, attract the monocytes or the macrophages. Once these monocytes and macrophages are attracted towards the site, when they get recruited, they start releasing lots of inflammatory mediators again, like your cytokines and your LDL. Your low density lipoproteins get oxidized and then further lead to again stimulating your endothelial cells to further release your chemokines and then again attract more amount of monocytes to the recruitment site and then express lots of adhesion molecules, thereby leading to accumulation of your macrophages, and then finally these macrophages will further liberate lot of growth factors and then leading to proliferation of the smooth muscle cells and then leading to closure of your lumen. What are the potential biological mechanisms that can link your periodontal disease with that of your atherosclerosis? Now, you know, atherosclerosis and periodontal disease are both inflammatory diseases. So obviously there is involvement of your monocytes or your immune cells. Now, once there is a hyper-responsive, because of the chronic inflammation that is happening, the monocytes are under a constant pressure to secrete more in amounts of, they're constantly in a active phase to produce lots of inflammatory mediators. Apart from being because of chronic inflammation, apart from being constantly stimulated, there can be certain kind of a genetic influence which is producing or which is making these monocytes into turn out to become your hyper responsive monocytes or macrophage phenotypes. Now this hyper responsive ones are going to secrete more and more amounts of these inflammatory mediators, and then periodontal infection, because of the constant influx of your bacteria, there's a constant stimulus there, leading to more and more amounts of your interleukins, prostaglandins, TNF alphas, and so on, and thromboxane, and then leading to changes in the vasculature, that is your endothelium, smooth muscles, and then monocytes, and then even platelets. And this again having the same kind of an effect which is seen in your atherosclerosis. Therefore, you can link the thing between your periodontal infection and your atherosclerosis. Now, if you see, there's one more, if you look into the blood viscosity, okay, now the blood viscosity is increased mainly for one reason. The first thing is, now as a result of your inflammatory process, there is an increase in the fibrinogen content with an increased blood cell or the white blood cell content, and your increase in the von Willebrand factor. Now because of this, all these three increases in all these three systems, there is a increase in the blood viscosity, thereby leading to any form of ischemic heart diseases. Now linking, let's see what is the link between your periodontal diseases and your respiratory diseases. If you see, the respiratory diseases contribute considerably to the morbidity and even the mortality in human populations. Lower respiratory tract infections, that is the third most common cause of death in the world, especially your COPD, which is the obstructive form of chronic pulmonary disease, which is the sixth leading cause of mortality. What are the potential mechanisms that you can link your respiratory diseases, be it pneumonia, be it COPDs, or be it any kind of respiratory infection, with that of your periodontal infections? Periodontal infections, how can you link it with that of your respiratory infections? Now the first one is, your oral pathogens, especially your periodontal pathogens, that is your P. gingivalis and your A. comitans, may be aspirated into the lungs. Okay, as a result of which, once they are aspirated into the lungs, the periodontal diseases, they have the capacity to produce certain enzymes within the saliva, as a result of which this modifies the mucosal surfaces to promote adhesion, and then they also help in colonization by the respiratory pathogens, and they destroy the salivary pellicles on the pathogenic bacteria, and therefore they can cause, this is associated mechanism in causing the respiratory the periodontal infections, causing any of the, or exaggerating the respiratory infections. So apart from that, the third important feature is your reservoir of cytokines. You have lots of cytokines produced as a result of periodontal infections. So this also can be a mechanism of explaining the link between the three. So I repeat, the three important links are your presence of oral pathogens, which can be aspirated into the lungs. Once they get aspirated, now because of the periodontal infection, there can be liberation of a lot of enzymes within the saliva, which causes the mucosal alteration of the tissues, and then they promote the adhesion of these bacteria onto the mucosal surfaces because of the alteration that is caused, and then they help in the colonization of the respiratory pathogens. And then finally, they destroy the salivary pellicles on the pathogenic bacteria, and therefore, leading to the increased they get more prone for the infection. Apart from that, you have your cytokines, which are released as a result of your periodontal infections. That also can act as a reservoir. Now, how do you take care of preventing these ingestion of your periodontal microorganisms into the lungs? One, selective decontamination, either a topical application of non-absorbable antibiotics or antiseptics like chlorhexidine gluconate rinses, and a thorough oral hygiene maintenance, especially mechanical debridement by toothbrushing, interdental cleaning, and even tongue cleaning of your tongue coatings. And then you can also incorporate something called as a full mouth disinfection. Now, how is your periodontal disease affecting your or resulting in an adverse pregnancy outcome? Let's see the first altered or adverse pregnancy outcome. The first one would be your preterm low birth weight. Now, what is preterm low birth weight? When an infant is less than 2,500 grams, and when the infant is born less than the normal time of gestation, then you can call it as a preterm low birth weight. Now, what is the mechanism of this? Now, you know normal physiology of labor is for the uterine muscles to contract and then leading to labor, you need certain inflammatory mediators related through your or produced through your cyclooxygenase pathway, especially your prostaglandin E2 and F2. And how can you link your periodontal infection to that of your preterm low birth weight? You know that periodontal infection is a chronic inflammatory disease that we have discussed repeatedly. It's a chronic inflammatory disease. So as a result of which there is a lot of prostaglandins, or there is an repeated activation of these defense cells, because there's a constant recruitment of your defense cells into the area of disease, and therefore there is a lot of production or a lot of activation of your inflammatory pathways, especially your COX pathways, leading to more and more amounts of production of your prostaglandins. Now, this can cause because of the increased presence of these prostaglandins at a very more amounts in due to the periodontal infection, this can result in an early uterine contractions, leading to an early preterm delivery. Now, the second outcome of adverse pregnancy outcome would be your preeclampsia. Now, preeclampsia basically it's a common it's basically a condition which has three things. You have your hypertensive disorder, and then associated with increased proteinemias. Okay, it continues to maternal and infant morbidity and mortality. Basically, what happens in preeclampsia is there is a combination of this oxidative and inflammatory changes, or atherosclerotic like changes which happen within your placental tissues, okay, and this will result in preeclampsia. So basically it's a hypertensive syndrome. Now the hypothesis is that the maternal exposure to periodontal disease or infection will lead to your development of preeclampsia. How is, again, it is related to your increase in the blood viscosity, increase in the inflammatory mediators, causing a smooth muscle cell proliferation. So they've clearly mentioned that there is some kind of an atherosclerotic kind of a lesion that is seen in placental tissues. How do you link your periodontal diseases with that of your diabetes mellitus? You know, diabetes mellitus is one of the most important metabolic disorder. It's an endocrine disease or endocrine pathology wherein there is excessive production, there is decreased production of insulin, as though it's not able to combat the presence of glucose in the blood. Now, insulin, the function of insulin is to reduce the glucose in the blood. Now, when the secretion of insulin is decreased, or there may various mechanisms by which your diabetes mellitus can develop. One is decreased insulin secretion. The second one can be, though the insulin is secreted in the body, but the cells are not able to take up the glucose. Either there is some kind of a resistance to the cells offered and they're not able to take up the glucose, or else there can be an antibody response wherein your insulin is decreased, mainly probably as a result of destruction of your beta cells of Langerhans of the pancreas, therefore leading to decreased production of insulin. Now, the diabetes is basically a rare it is a most common metabolic disorder, and then there is a dysregulation in the production of your insulin, as a result of which your glucose is at a higher level in your bloodstream. Now, there is a typical triad of symptoms which is seen in diabetes mellitus individuals. These include your polyphagia, polydipsia, and polyuria. Now, what is polydipsia? Is an increased thirst. Polyuria is an increased urination, and then polyphagia meaning an increased hunger. So all these three are the ones which are characteristic triad symptoms of your diabetes mellitus. So you have two types of diabetes mellitus. You have type 1 and type 2 diabetes mellitus, and there's something also called as a gestational diabetes, which is seen in pregnant individuals. Okay, now this most of the times what they say is that the women who have experienced this gestational diabetes have the tendency to develop diabetes mellitus even at a later stage. Okay. Now, what is the influence on the pathogenesis of periodontal diseases? There are three mechanisms that have been explained how you can link diabetes mellitus with periodontal infection, or the periodontal infection can be linked with diabetes mellitus. The first one is the role of age and rage. Okay, I will describe a little in detail about this. It's not very important, but still you need to know what is this age and rage. And then alteration in the capacity for repair and altered native immune responses. Now first one is age and rage. Now what is age? Ages are nothing but your advanced glycation end products. Now these advanced glycation end products are formed as a result of your protein clubbing with the glucose. You know the diabetes, they have excessive amounts of glucose in the blood. So now this glucose can go and club or can combine with any of the proteins in the body, and they produce something called as an amidori product. Now this amidori product has a capacity to reverse back. Before the amidori product is formed, there's something called as a Schiff base. Now this Schiff base, till the Schiff base, you have the capacity for the thing to reverse back, the protein to reverse back. Means for the unbinding of your protein with the glucose to happen. But then once the amidori product is formed, there is less chances of reversible condition. So it becomes an irreversible situation. As a result of this complex, what you get are the advanced glycation end products. Now these advanced glycation end products, what do? They make the collagen which is present in the body to become insoluble. So this insoluble collagen can't be broken down. So if the insoluble collagen can't be broken down, that means to say that you don't have enough renewal mechanism that is happening. The body is trying to break it, but then because of the insoluble nature, you can't the collagen can't be broken down, as a result of which, even though the new collagen is produced, the old collagen can't be eliminated. Now diabetic individuals do have some problem called as a altered immune response. Now these diabetic individuals, if they are uncontrolled diabetes, they're very much prone to infections. And then because of this, there is also because they are as they're more prone to infections, there is something called as a capacity for repair. Now the tissues always are undergoing repair. Though there is destruction, there is a kind of a repair that is happening always. But then what happens is, in case of your diabetic individuals, that the collagen synthesis is decreased, and even your the repair process is hampered because of the collagen synthesis. And apart from that, it is also affected by your alteration in your immune responses. So the patients get more prone for infections, and then there is altered response to repair, that is wound healing is delayed. Now what is this rage? Now age is advanced glycation end product. Now rage are the receptors for these advanced glycation end products. Now the availability of these receptors will become more, because more and more age is produced. So once they go bind, then they become there is a constant decrease in the capacity of the collagen to be broken down. Now let's see the periodontal disease and its association with rheumatoid arthritis. Rheumatoid arthritis is again an inflammatory disease, and then periodontal infection is also an inflammatory disease. Now this is the possible mechanism or which links your rheumatoid arthritis with that of your periodontal infections. That periodontal infections are mainly caused by a gram-negative anaerobic bacteria, and as a result of the exposure to the constant endotoxins and the lipopolysaccharides, there is a constant stimulus of your immune responses, and then there is increased production of your MMPs, that is matrix metalloproteinases, also called as your collagenases, gelatinases, stromylysins, matrylysins, and so on. So apart from the elevated MMPs, you have elevated levels of interleukin 1, interleukin 6, TNF alpha, and even prostaglandin E2 and C-reactive protein. Again, C-reactive protein is an acute phase reactant. As a result of all these, there is a connective tissue and bone loss, right? There is a breakdown of bone and connective tissue destruction, further leading to bone loss and impairment of the function of the tooth. Similarly, if you see your rheumatoid arthritis, again it is a super antigen triggered reaction, wherein because of which there is an increase or elevated levels of these MMPs and your interleukins and prostaglandins and CRPs, and then leading to connective tissue and bone breakdown, and then impairment of function. The one which is linking the both are chronic inflammatory diseases. That's one important thing. And the second is there is a genetic susceptibility in both the periodontal infections and even rheumatoid arthritis. And the third one is environmental factors. Environmental factors like stress, your smoking, all these, or a previous history of the inflammatory disease, all these can cause your link between your periodontal. They are the common risk factors for both of them. Now, what is the importance of periodontal medicine in clinical practice? Why do we need to know the significance of periodontal infection? So, the proper use of the available knowledge and the data that is provided to us through a lot of research can help us as a dentist to treat the patient overall in identifying what is the source of infection, and if the periodontal infection can be eliminated to prevent the further consequences or further aggravation of any of the systemic diseases. That's why it becomes very important that as a dentist or an as a periodontist, you do recognize your infections of the oral cavity that can have a role in the causing systemic diseases. That completes your periodontal medicine. Thank you.